Hello friends, welcome to my channel V's Medicine Diaries. So in this video, we are going to look into patent ductus arteriosus, PDA. Okay, so we are mainly focusing on the hemodynamics in PDA. Okay, which is usually a very important part of this acyanotic heart diseases. Okay, so let's go to the topic without wasting any more time. So what do you mean by patent ductus arteriosus? Patent ductus arteriosus. Ductus arteriosus patent. Okay, so where is this ductus arteriosus present? Okay, and what is it? Ductus arteriosus is nothing but it is just a connection. Okay, it is just a connection between the aorta and the pulmonary artery. Okay, as you can see in the figure. Okay, it's just a connection between the aorta and the pulmonary artery. And what is its side, or where is this ductus arteriosus present? Okay, it is present just distal to the left subclavian artery. Okay, it is just after the branch of the left subclavian artery. Okay, from the aorta. Okay, it is, you can see that left subclavian artery is going like that, and you can see the patent ductus arteriosus. Usually, this ductus arteriosus closes just soon after birth. But if it doesn't close, then that condition is called as patent ductus arteriosus. So now let's go to the hemodynamics. So what is happening here? Okay, we can see that always the pressure inside the aorta will be greater than the pressure inside the pulmonary artery, right? So there will always be a left to right shunt in this condition. Okay, left to right shunt from the aorta to the pulmonary artery through the patent ductus arteriosus. So what happens then? Okay, there will be increased blood in the pulmonary artery. So due to this blood flow, continuously from aorta to the pulmonary artery, that is both in systole and diastole, there will be flow from aorta to the pulmonary artery. So we can hear a continuous missionary murmur here, okay, whose peak is at S2. Okay, the intensity of the murmur will peak at S2. Okay, that's a very important point. Now the question comes, where should we keep the stethoscope to hear this murmur? Okay, it is in the second left intercostal space close to the sternum. Okay, second left intercostal space close to the sternum. We have to keep the stethoscope in order to hear this continuous murmur. Okay, so now let's continue our hemodynamics. So there is more blood coming into the pulmonary artery than the normal, right? So more blood comes through the pulmonary artery, it will go into the lungs, and through the lungs, through the pulmonary veins, more blood is coming now into the left atrium. Okay, so in order to accumulate the more blood, the left atrium has to enlarge. So the left atrium enlarges. Okay, the left atrium enlarges to accumulate this coming blood. Okay, increased blood, and then this increased blood flows through the normal mitral valve. Okay, this increased blood flows through the normal mitral valve into the ventricle, okay, into the left ventricle. So what happens here? You can hear a murmur in the mitral valve area also, and also due to this reason the S1 will be accentuated, and you can hear a delayed diastolic mitral area murmur. Okay, so this is because increased blood flow through a normal sized valve. Okay, so that's why we can hear a delayed diastolic murmur here. Okay, so now the blood has reached the left ventricle. So in order to accumulate the more amount of blood, the left ventricle also has to enlarge. Okay, so the left ventricle also enlarges. Okay, enlarges in order to accumulate the upcoming blood, and then this will contract. Okay, this left ventricle contracts and ejects out the increased amount of blood through the aorta. Okay, through the aorta, this will eject out the blood. Okay, the ventricle will eject out the blood. But here, since increased amount of blood has to be pumped out, okay, since increased blood has to be pumped out from the left ventricle, we can see that the systolic time, or the duration of the systole is increased, or it is systole is prolonged. The left ventricular systole is prolonged. Okay, the word is important. So the left ventricular systole is prolonged, and as a result, what happens? Okay, the aortic valve will close a little bit late. Okay, there is a delayed closure of the aortic valve, and so the A2 part of the S2, okay, the second heart sound will be delayed. Okay, sometimes if there is a large left to right shunt in this PDA, then there can be paradoxical split. That is, P2 comes before A2. Okay, so that can also occur in severe cases or large PD. Now we have increased blood in the aorta also. So the aorta has to dilate a little, right? So since the aorta has to dilate, okay, there will be an aortic ejection click also. Okay, ejection click will also be heard just preceding this continuous murmur. Just before this continuous murmur in PDA, we can see here a ejection click, okay, which cannot be usually appreciated. So this is what is happening in PDA. So we have continuous left to right shunt. As a result, the pulmonary artery will take more blood to the lungs. As a result, there will be one complication, that is pulmonary congestion, and then the increased blood will come to the atria, left atria. The left atrium enlarges, and this increased blood flow comes through the normal sized mitral valve into the left ventricle, which also enlarges, and the systolic duration is increased, okay, and it ejects the increased amount of blood into the aorta, okay, and the cycle repeats again, okay. So all this is happening, okay, all this normal hemodynamics is happening, or left to right shunt is happening only when there is normal pulmonary arterial pressure. But there can be conditions where pulmonary arterial pressure will be increased, okay, and there will be right to left shunt, okay, and in that case the situation is different, and that condition is usually called as Eisenmenger syndrome. And to mention, the other important complications and presentations of PDA include congestive cardiac failure, usually presented between the 6 to 10 weeks after birth, or and so on, okay. So what is its management? Usually this PDA closes, okay, PDA obliterates by about 1 month itself, okay, spontaneously it will close, spontaneously it closes, but in some other cases we have to intervene and we have to do catheter based closure, okay? And otherwise within 2 weeks we can give NSAIDs like indomethacin, ibuprofen, etc., which is a medical management, okay. So that's all about PDA, and I hope you have understood the concepts very clearly, and if you have any suggestions, please comment it. Please like, share and support. Have a positive mind, positive vibes, positive life. Keep smiling, live happy.